Hello, everybody. I'm bringing greetings from Tirana, Albania, and I would like to thank you, the organizers, for inviting us in such an amazing activity. Thank you. So, my lecture is about fungal rhinosinusitis and our experience in diagnosis and treatment. Fungal rhinosinusitis is the most appropriate term to describe fungal infection of the paranasal sinuses because concomitant involvement of the nasal cavity is seen in most cases. Although fungi are normal saprophytes of the nasal cavities and paranasal sinuses, under particular conditions, they may lead to specific sinonasal diseases. These conditions are favored by hypoxia and low intrasinusal pH values due to disturbance of ventilation because of closure of the natural osseum of paranasal sinus and impairment of the mucociliary clearance. The causal species of fungal rhinosinusitis are Aspergillus, mucormycosis, Candida, Bacillomyces, etc. Pathophysiology. The detailed pathophysiology has not been fully explored, even though both the genetic background, the immune status of the affected hosts, have been proposed to be involved in the underlying etiology, along with the involvement in an anatomical obstruction, environmental exposure, and the toxicity of the microbes. This is the Deschazo classification. He made it in 1998 of fungal rhinosinusitis. Fungal rhinosinusitis have been classified in two categories, the non-invasive forms and the invasive forms. The non-invasive forms, which typically affect immunocompetent subjects, include fungal boll, it was called once mycetoma or aspergilloma, and allergic fungal rhinosinusitis. And the invasive forms, which typically affect immunodeficient subjects, are acute fulminant rhinosinusitis, chronic invasive fungal rhinosinusitis, and the granulomatous fungal rhinosinusitis. Fungus boll is the most spread of all of them and generally affects immunocompetent subjects. It is an extramucosal fungal proliferation characterized by a mass of fungal debris and mucus that grows progressively in the sinus cavity, completely filling one or more of the paranasal sinuses, but usually one, and sparing the underlying mucosa. Fungus boll is more often unilateral, rarely can affect more sinus cavities. It usually occurs in adult subjects and has a predominance for the female gender. It differs from allergic fungal sinusitis. The last one affects generally more sinuses. It's mostly localized at the maxillary sinus and followed by frequency from the sphenoid sinus. The pathogenic causal agents of fungus boll is Aspergillus, a fungus belonging to the Asomycetes family. The most pathogenic to humans is Aspergillus fumigatus, and then it's followed by Aspergillus niger and Aspergillus flavus. There are some predisposing factors to fungus boll infection of the sinuses, and these are tooth endodontic treatments for tooth disease, diabetes, Wegener granulomatosis, asthma, lymphoproliferative diseases, and sometimes the anatomical variants like deviation of the nasal septum. Signs and symptoms. The fungus ball is typically asymptomatic in the early stages, and signs and symptoms may take several years to appear. Moreover, its clinical manifestation is often non-specific. It's variable and includes these signs: nasal congestion, purulent or blood-stained nasal discharge, headache, craniofacial pain, impaired sense of smell, postnasal drip. Diagnosis made by using clinical findings and radiologic findings. Computed tomography, CT scan, without contrast, is the most used technique for diagnosing of the fungus ball. Fungus ball has a distinctive radiographic appearance, which includes obliterated sinus and hyperdense focal areas that mimic a foreign body, a metallic foreign body in the sinus. Sometimes, if there are doubts of the diagnosis, we can use MRI. Histopathological examination makes the diagnosis. Treatment of the fungus ball. Surgery is the treatment of choice for removal of fungal debris from the affected sinus and reestablishing proper ventilation and drainage. The pure endoscopic approach is widely considered the gold standard in the treatment of paranasal sinus fungus ball due to its low morbidity and easy access to the affected paranasal sinus. Symptomatic fungus ball is an indication that sinus surgery is required. Following the complete surgical removal of the fungus ball, antifungal medication is not usually recommended. For the patient which are asymptomatic, there are no guidelines for the treatment or not treatment of them. So I think it's a little bit individual. It depends on the surgeon, the doctor. After fungus ball, just a short description of other types of fungal rhinosinusitis. Allergic fungal rhinosinusitis is an immune-modulated disease entity defined largely by the presence of allergic fungal mucin, which is a thick eosinophilic secretion with characteristic histologic findings. Bent and Kuhn established the criteria of diagnosis, dividing it in the major criteria, which include type 1 hypersensitivity to fungi, nasal polyposis, characteristic CT scan findings, the presence of eosinophilic mucin without invasion of the mucosa, positive fungal stain of sinus content removed at the time of the surgery. And minor criteria include history of asthma, unilateral predominance of disease, radiographic evidence of bone erosion or remodeling of the bone, fungal cultures, presence of charcot-laden crystals in surgical specimen eosinophilia. The agents that cause allergic fungal sinusitis are the bipolaris, curvularia, exerohium, alternaria, and aspergillus. Signs and symptoms. They are usually similar to chronic sinusitis, which include nasal obstruction, purulent nasal discharge, postnasal drip, and allergic mucin in sinus. It's characteristic, the IgE are very high in this kind of disease. Usually they are, let's say, even 1,000, when usually they should be under 50. IgE is used as an indicator for treatment efficacy and for the differential diagnosis. Treatment includes endoscopic surgery, corticosteroids, and systemic and topical treatment, and antifungal or immunotherapy. Acute fulminant fungal rhinosinusitis, it has a high morbidity and mortality rate, happen in immunocompromised patients, HIV/AIDS, diabetes. uncontrolled diabetes, malignancy, etc. Symptoms include fever, facial pain, nasal congestion, nasal serohemorrhagic discharges or epistaxis. Intraorbital and intracranial spread is possible. Histologically, the mucosa shows infection, vascular thrombosis. Aspergillus and Rhizopus is the most found factors that cause the acute fulminant fungal rhinosinusitis. Rare pathogens is Fusarium. A complication of this disease can be cavernous sinus thrombosis, cerebral invasion, intraorbital invasion. Treatment, emergent surgery, removing of necrotic or debriding the necrotic tissues, intravenous antifungal therapy, and very careful follow-up. Chronic invasive fungal sinusitis is a slowly growing invasive fungal infection characterized by invasion of numerous fungal organisms into the sinonasal mucosa with rare angio-invasions. It happened in immunocompromised patients. Long-term sinusitis symptoms are the symptoms of this disease. Persistent, these symptoms can be persistent or recurrent, and the causative agents are Aspergillus fumigatus and mainly bipolaris. Treatment includes endoscopic surgery, systemic antifungal therapy, amphotericin B and ketoconazole, and follow-up. And the last one is the chronic granulomatous fungal rhinosinusitis, which happens usually in immunocompetent patients. The infection is characterized by the presence of submucosal granulomatous inflammation, rare fungal hyphae, and extensive fibrosis. The most common associated fungal organism is Aspergillus flavus. Treatment consists in debridement and antifungal intravenous therapy. Our study. We performed a retrospective study and analyzed the clinical records of 27 patients with fungus boll that was diagnosed and treated in our clinic during the period 2013 and 2018. Diagnosis was established by history and clinical examination, CT scan, and histopathological findings. 22 from them, 21.4% were women, and 18.6% were men. Age ranged from 30 to 71 years, with mean age 51.6 years. The symptoms were facial pain in 21 patients, 77.7%. Nasal congestion 19, 70.3%. Nasal discharge 15, 55.5%, and headache 29.6%. 81.4% of patients had maxillary sinus involvement, and 18.6% had sphenoidal sinus involvement. All patients were treated with endoscopic surgery, which consisted in removal of fungus boll from the affected sinus and widening of natural ostium. No systemic antifungal therapy was required. We made a very careful follow-up. We had just one patient with recidives. I would like to present some interesting cases, and the case one is a patient, 30-year-old, female, was presented with facial pain and nasal congestion. CT scan revealed obliterated maxillary sinus with hyperdense focus in center, metallic-like image. In clinical examination, it was seen mucosal edema of the left side. She underwent endoscopic surgery, wide antrostomy, of the left maxillary sinus, and diagnosis of fungus boll was made by histopathological examination. This is the CT scan, and we can see the focus in the center. The sinus is totally obliterated, And in the middle, we can see this hyperdense focus metallic-like image. This is the view in the coronal view, and this is sagittal. The interesting part of this case is that 1 year after the surgery, the patient presented with a toothache and, let's say, a little facial pain. A new CT scan was made, and it reveals a foreign body in maxillary sinus. Is this one? You can see it is a gutta perca in the floor of the maxillary sinus. That is the other view. We consulted a dentist, and he said it is a gutta perca, which is a material used for endodontic treatments. And the sinus after surgery was normal. She was treated by the maxillofacial surgeons, and they removed that material. And, and the patient is normal, is very good now. Okay. The second case presentation is a 68-years-old woman presented at our clinic with headache. She revealed that no nasal congestion or nasal discharge or other complaints. A CT scan was performed, and it revealed an obliterated left sinus, sphenoid sinus. No hyperdense foci were found. The patient underwent endoscopic surgery of the sphenoid sinus. We can see here the left sphenoid sinus, which is obliterated. And here is the video of the surgery, endoscopic surgery. And she has fungus ball, which is filling the sphenoidal sinus. Yeah, you can see the fungus ball. I think it's clear the fungus material, yeah, that is coming out. Topical treatment was use of saline solution for rinsing the sinus, and no recidivum was noticed in this patient. And last one case, which is fungus ball of the right maxillary sinus with, this is a CT scan with the characteristic hyperdense focus in the center. And I would like to show the video of antrostomy for removal of the fungus ball.